robot-assisted gastric ESD. And briefly presenting the case, the patient is male, 69 years old. Gastric neoplasm was identified during screening endoscope. It was biopsy confirmed 4 months ago. He had no medical and any medication history, but a current smoker. So here are 3 different views of images. White light image shows erythematous and irregular mucosa at the anterior wall of the antrum. And the next MBI images reflect the brownish discoloration and central depression with irregular surface mucosa. Near focus MBI view showed no definite demarcation line between the background mucosa and the target lesion. With regards to the microsurface pattern, the shape was the tubular, and regarding the microvascular architecture, the shape was the little bit dilated, but no irregularity. So in these cases, according to the Paris classification, gastric superficial neoplastic lesion was type 2A plus C because of the central depression. Regarding the Vienna classification revised, low-grade dysplasia is considered non-invasive gastric neoplasia, categorized classification 3. So the patient is required for endoscopic resection due to the possibility of malignant transformation.
Would you please start the procedure?
Okay, let's start our procedure. Now I'm investigating the target lesion. In white light image, you can see the slightly elevated and central depressive lesion at the anterior wall of the antrum. I'll change the MBI image. As you can see, we can see that this plastic lesion at the anterior side of the antrum. I changed the near focus MBI view. In near focus MBI view, the brown colored line is the subepithelial capillary network, and the white line is the marginal crypt epithelium. So if we describe this lesion, microsurface pattern plus microvascular architecture, you can see microvascular pattern is a little bit dilated caliber, and the surface pattern is tubular, and here some oval shape. So I think that this is compatible to low-grade dysplasia. And now I'm going to start the marking process.
How many centimeter is the lesion? It looks very big.
Yeah, I usually do the circumferential marking of distance from the target lesion 2 to 5 millimeter. So if I mark this lesion, I'll mark at this point.
The size of the lesion looks like maybe 2 centimeter, I think. The shape of the lesion is not that the round, and the shape is a little bit irregular, and then the patch-like mucosa shape. So as you can see, the demarcation of the lesion is not that clear. So we have to observe the mucosal surface thoroughly with the near focus or the magnifying scope, and then we need to check whether which side is the the neoplastic lesion. So I think maybe 2 centimeter long length, and then 1.5 centimeter width would be the size of the lesion.
Okay.
Professor Jeon, do you usually, when you decide the marking location, do you usually use the NBI only or other chromoendoscopy or using the only NBI before the marking?
In my cases, I usually marking with only NBI because the NBI image accuracy is over near focus in case, so over 85%. So it is sufficient to use only NBI.
Yeah, we also use only MBI. Do you use?
Yeah.
use
Sometimes
the
in
vital
case
strain?
of the serious atrophy or metaplasia, in the case the chromoendoscopy using the endocamine or is very helpful sometimes. So I usually use the both items for
Okay, now
marking.
I'm started to
Yes, we
inject.
agree about the opinion.
Yeah.
What's your solution? Injection solution? What is the injection solution for this?
Now I'm using the 1-to-1 mixture of the normal saline and 0.4% of the hyaluronic acid solution.
Normal saline plus hyaluronic solution?
Yes.
Mixture, okay. That's the usual procedure for every location of the stomach?
No, because in the case of the upper body, I use the 100% of the hyaluronic acid because it depends on the submucosal fluid cushion everlasting time. So in antrum, because it is
Usually, the lesion located on the antrum side or lower body side, usually the normal saline only solution would be enough to maintain the submucosal cushion while doing ESD. But it's sometimes it depends on the endoscopist who wants to who doesn't want to repeat the submucosal injection during the procedure. In that case, some endoscopists just mix the thicker solutions such as hyaluronic acid or glycol, like colonic EST. But usually, in our center, we usually use the only normal saline solution. But today's a live demonstration, so we have to save some time. So we decide to mix the hyaluronic acid and to maintain the submucosal cushion.
Yeah, okay. It depends on the region's characteristics and then endoscopy's preference, right?
Yes, that's right.
Okay, thank you.
So I guess that you injected all the lesion and you're doing all the incision because then you're going to use the robot. Is it correct?
Yes, we will going to use a robot, but the ESD has some the steps like actually the first step would be as you can see, the circumferential incision would be the first step, and then robotic assisted ESD device will be joined to maybe the second step to help the enhancing the submucosal dissection. So the operator can decide when the robotic devices will be needed. So maybe Professor Jeon will decide.
That probably you do first all the incision and then you put the robots.
Yes.
Yeah, actually, it depends on the location of the lesion, but today we are going to use the robot-assisted the ESC. So we are going to dissect the incision all around, all the way around.
What
the lesion.
what knife are you using now?
Now I'm using the dual knife J made by the Olympus.
And are you injecting while you do the incision, or you only do the incision without injection?
Sorry?
Maybe this is the only dual knife without injection solution.
injection, okay.
Yeah.
Injection
sometimes-
function.
Uh,
This is it has the injection function also. So
Ah,
that we could inject some injection material through the needle into the submucosal layer. That's right.
Yeah, because usually our nurse inject while we are cutting.
Yes,
So you're
that's right.
always creating a cushion.
yeah, there are
So-
several. Go ahead. Yeah, sometimes we have various kinds of different type of the knife. Yes, some only dual knife, or sometimes dual function, including the knife and then injection solution. Yes, simultaneously.
We only use knife where you can inject. For us, this is our standard. So we inject throughout all the procedure.
Simultaneously.
Yeah.
Yeah, that's better.
Okay, now I have finished the peak cutting.
Congratulations, very fast.
Yes.
I
well done.
I start to trim for more visualize the submucosal layer in the proximal part.
Okay, so do you want to change the endoscope, which is equipped with a robotic device now?
After finishing the trimming, I exchanged my endoscope with robotic system.
Okay, I think just a few minutes later, he will change the scope with the robotic assisted device was equipped.
What setting? What setting are you using now for this section? It is
You mean the
Swift.
electrosurgical unit, right?
Yeah, it is Swift Quag.
Yes, we use endocut eye mode for the cutting and the swift coagulation for the coagulation
이 정도
during
충분한
the
것 같아.
Effect. What effect? Is it effect 4?
endocut eye effect 2.
No,
and
in the
cut
Swift.
duration
The Swift. What effect is Swift?
You mean for the swift coagulation?
Yeah. So usually
Swift
we use
coagulation.
the effect 4.
Yeah, effect 4. Effect 4 and
Yeah.
the power is 50 watts.
Yeah, it's the same. Keum is the one you
Yeah.
use.
Oh,
Swift,
yes.
Quag, yeah. Ricardo as well.
Same setting. Over.
네.
Erbе.
I'm not sure that you need a robot. You are so fast.
So yeah, they can use another
You
robot
are- you
assisted
are a robot.
endoscope.
Yes,
You
that's
are a
right.
robot
But,
yourself.
Yeah, we
Yeah,
are
but,
really waiting for your robot.
yeah.
Okay, I exchange my endoscope with robotic system.
Okay. Yeah, actually, this reason is not that the difficult side, but today is the live demonstration, so we
Okay, let's
have
see.
just a limitation of time, so we just choose the appropriate location to show you. And okay, so we're going to mount the robotic device on our endoscope, and let me show you how to install the device shortly. And come here.
Okay, we can follow you.
Thank you. And camera will follow me. Okay. I will show you the how to install the robotic device. It's not that easy. So here is the device package, and which is sterile state, and then unpack the package. Okay. And this is the sterile state robotic device. And here is the cartilage and the wire.
이거 너무 이쪽으로 가는 원래 이쪽으로 붙었는데.
And this is the head of the device. And which has the you can see the arm and then wrist joints and then hand, which is can grip and release.
Please focusing more precisely.
Yes.
Focus more, please.
Can you see this clear?
Little bit more, please. Okay,
Oh,
much
yes.
better.
Yeah.
Yes.
Uh-huh.
Here is the head of the device, and then here is the arm, and then the wrist, and then the hand.
Yeah. Is it
And then
very-
this is the cartilage to be inserted into the driving unit. And then you can see that this driving unit has two controller, the button type and this lever type. But any type of controller can be used depending on the operator's preference.
Wow.
Okay, you can just fit. This is the Olympus endoscope, and you can just fit in just to the at the end of the endoscope. It's not that difficult. Just you can just fit in at the head of the device at the tip of the endoscope, and you can see. I'm not sure. Can you see this marker? Here is the arrow marker here. Arrow marker here,
Yeah. We can see.
and then you need to align this marker to the working channel
Okay.
and just fit in. And then taping can be done for the fixation. And then cartilage is inserted, and then you can see the display. Can you see the display?
Yeah.
Yes.
Okay. And you can see the next place. You can just follow the direction. There is some information about the installation. And okay, this is the inspection display showing the inspection status. And I'm going to use this lever type controller and follow the direction. And you can check the movement. And first, the hand grasp, open
Wow.
and close, and
Oh.
grasp, release, and grasp again. And then the next lever is control the wrist. So wrist, this side, 90 degree, and the other side, 90 degree. Total 180 degree can be gained by this device. And then the next one lever is the arm, controlling the arm, 90 degree up and 90 degree down. So you can check the normal movement. And lastly, the roll motion. And the other side roll to the 90 degree. And the upper side, 90 degree roll motion. Can you see that?
Yeah.
Very well.
Very
Okay, and then you
clearly.
can
You can
okay,
see.
and then you can see after inspection, and you can see the panel, and there is 4 check boxes underneath, and then now the device is ready to go. And then I think this installation process is intuitive and easy to follow. And okay, this device is ready to go. And Professor John, are you ready? Okay, let's move on to the patient procedure.
And do you have also for the colonoscope, or you have only for the gastroscope?
You mean this device or
Yes.
other device?
No, this
For
device
one,
is only
this
for
device,
upper or also for lower?
yeah, this can be used for upper and also for lower. But I will in this afternoon we are going to show the colon case. But unfortunately we cannot use the robotic device for the colon in this afternoon. But anyway, we're going to show you the robotic device for lower we can use this device for lower also, but as you can see, there is the protruding arm, the controlling arm, so that we can use this device maybe only for the rectum. But if you want to go further up to the sigmoid colon or descending or transverse, then up to ascending colon, it's not easy to advance with this device on. So that's why maybe this device usually can be used usually for the upper GI side.
Yeah. And is it easy to introduce the device in the esophagus? Is it simple to advance the robot in the mouth and then
Yeah,
the
this one.
esophagus?
Yeah, we use over two.
You use the overtube.
Yeah. When we insert this scope with this device on, so with the over two, it's not that difficult. Just follow the through the over two. We can just insert this endoscope with this device on. Can you start?
Yes.
Okay.
I'm going to start the dissection. As you can see, the mucosal flap falls down to the basement. So it is highly recommended to grab the mucosal flap to expose the submucosal plane. Then I'll start to grab the mucosal flap.
Already the submucosal solution is decreased, so is it better to inject more or?
Yeah.
Yes,
Here-
maybe more injection is needed, but I think we are using the robotic
This is
device, so I think we can just pull up and then make the a little bit submucosal space widening, and then we can make the dissection plane appropriately. And so we want to just try first without additional submucosal injection.
Yes.
Okay, he is studying submucosal dissection. Okay.
During the procedure using the robotic devices, another assisting person is waiting for next to the endoscopist, right?
Yes. Actually, as I showed you, there's two controller, the button type and lever type, and then we can just attach the controller on the upper shaft of the endoscope, just under the controller side, and then if the operator is familiar with the movement and control this device, and the operator can do by him or herself. But if the operator is not that familiar with the control the movements, and then some other assistants such as other doctors or nurses can assist the movement and to control the arms and the roll motion.
No, the demonstration is fantastic. My only fear is that when you lift the lesion, you also lift the muscular plan that is behind the lesion. So you always need to be very superficial when you cut, because also the muscle can come out, especially in the colon. And so I feel that you need to be very expert to use because then you left the muscle.
Yeah, actually the robot looks like another hands inside of the patient's stomach. Yeah, right. Endoscope is another hands over there.
No, but it's important that he doesn't keep the lesion always at the same time. He lifted, then he leave, he lifted, then he leave. So you must be very dynamic also with robot. It's not just one procedure. And anyway, you need lifting. This is new because, for instance, a surgeon would not need lifting. After the surgeon leaves, he cut. We still need lifting to separate the muscularis from the lesion.
Yes.
네.
So,
Agree.
Kinam, do you feel that you need a randomized trial to use the robot, or is it so compelling? Is it so evident that it helped that you don't need any trial and you just can use it?
Yes, so actually, Professor Keum,
Yes.
yeah, do you have any data comparing the robotic devices using ESD as other conventional formal ESD procedures?
Yes, we've been conducting a clinical study since 1 month since 1 month since 1 month, and then we have more than 10 case, 10 to 15 case for the gastric ESD, and then when we compare the clinical outcome to the conventional the gastric ESD, I think the dissection time is almost in data is still similar. I mean, because we need to get some time. We need to some time to familiar with this device's the movements. So the dissection time is still not that short compared to the conventional ESD. But in terms of the exposing the submucosal layer, and also in terms of reducing the blind type dissection, it works. As you can see, we can expose the whole operation field by lifting up the mucosal flap, and then we can see the whole mucosal field, and also we can assume and we can make our own dissection plane. So dissection time, we need to more cases to see the absolute effect, but as for the reduction of the blind type dissection and the clinical outcome, it works, I think.
But I feel it also helps for bleeding because anyway you have more room to see where the bleeding is coming from, and you're not covered by the blood.
Yeah, Professor Keum, which is the best location or best characteristics of the lesion for using the robotic devices? ESD?
I think, maybe we need more the clinical the cases, but anyway, until now we did body side and also greater curvature and lesser curvature side and angle and from lesser curvature side, and all the sides are it's quite good to be applied with the robotic ESD device. So, and also maybe we can show you the after finishing the ESD, and we can show you the movement of this machine intragastric space, and how can we approach the body side and also the other less curvature side, this approach with this device, and then how the arm can move after finishing the ESG.
And actually, this robotic devices is commercially available in Korea, or?
Oh, actually, we got the Korean FDA approval 3 months ago for this type Alligator type robotic ESD assistant device. This device, but we could use a more different type and more the novel type of the robot assisted robot device maybe several months later. But anyway, this Alligator type is already we got the approval, but commercially still commercially we cannot yet buy this device in the market.
Yes, your procedure is almost done. So actually, we really wanted to see the more free motion inside of the stomach of the robot hand.
Yes.
After the procedure.
Maybe we can navigate some location, and then maybe we can show the how can we approach, and then also as the another professor told us that the bleeding control would be better to get some help from this endoscopic the robotic device, because we can expose the whole the submucosal the space, and then if there is some breathing vessel, usually if the 좀 놔보실래요? 한번 놔볼까요? 떨어지고. Okay. If we just release the specimen. 아예 놔보세요. Okay. And then you can see the because of the gravity, the flap is settled down. And then if there is a bleeding underneath the lesion, maybe we are very good at using the transparent cap and then penetrate into the submucous space and then find the vessel and then coagulate it. But sometimes it's not that easy. And then if we use this robotic device, and then 다시 잡아주세요. And then we can just grip the tip of the 잡아주세요. And the tip of the flap. And then lift. 들어주시고요. And lift.
Okay.
And then you can see the whole the operation field of the submucosal layer. So if there is the bleeding vessel underneath here, and then we can find it, and then we can just treat it.
That's nice.
So that's quite a good advantage when we're doing some this kind of procedure.
Okay, Professor Keum.
Yes.
Yes, the time is almost done, so please wrap
Yeah.
up this session, this case, please.
Already done.
Yeah, already done.
Yeah, we were counting the time, and then I think we spent just 35 minutes. So I think I thought that we have 10 minutes more, but it's already the time to move on. Is that right?
Yeah, within several more than 5 minutes. Within 5 minutes. You can more several minutes.
Okay, we have 5 minutes, right?
Yeah, several minutes more. You can use
Okay,
the
okay.
time.
Okay, that's not that difficult, because we are just follow our pace to dissect, because as you can see, just we can just finish this this kind of dissection quite faster.
Oh
than
yeah,
as
I'm
we
so
showed
sorry
you.
for
Yeah,
pushing you very
but,
sorry. So
yeah,
please
but
enjoy the several minutes.
we want to make just on time, so we dissect a little bit slower. You're
Because
dissecting.
Professor Jeon is really excellent. Yeah, doing the procedure right now.
Yes, and as you can see, as the ESD proceed a little bit further, and then you can see the specimen is moved upward more and more. Okay, to finish the lesion.
Wow, congratulations.
Okay, and
On your
we can just
performance.
grab the specimen, and then we can just remove it by the robotic device.
Yeah, also I wanted to say hello to robotic hands.
Okay,
Hello.
yeah, here is the over two, and then would you please? And we have only how many minutes? 4 minutes?
1 minute. 1 minute
Oh,
more,
1
please.
minute.
Yes.
1 minute.
I'm so
sorry.
sorry.
Okay. In the case of, we cannot show you the navigation of this is the way of insertion. 들어가 주세요.
1 or 2 minutes more, please.
Yes, and
Yes.
you can see the through the over two. Even though the device has the horn at the arm, but you can see the insertion is quite safe.
Can you suturing the ulcer with this robot, especially in the colon? Can you close the ESD defect with the clip and the robot?
Yes. And then we can show you. And 한쪽 잡고 당겨봐 주실래요? Maybe if we want to the close the this defect, and then you can just grab one side. 저쪽 잡아주세요. 저쪽. The one side of the end of mucosa 잡아주시고, and pull. 아니 이리로 당겨주세요. 당겨주세요. And pull the mucosa to the other side and approach them. And then we have one more walking channel, which
Yeah,
has which is
exactly.
Yes.
use the walking channel, and then we can use the conventional endoscopic clip, and then the clip
Wow.
at the side of the approximation. So maybe we can show you the clinical trial video in this afternoon when we are going to do for the colon DSC case.
I feel for colon is very important to close everything.
Okay, Professor Keum, the case is almost done.
Yes, we are done.
Okay.
Yeah. Okay.
Yeah. Congratulations on your excellent performance, Professor
Okay,
Keum
thank
and Professor
you,
Jeon.
thank you.
Thank you.
Yeah.
Okay.
Yeah,
And
thank you.
also we can enjoy your more cases in the afternoon session, right?
Yes.
Thank you very much.
Yes.
And hello to bye.
Yeah.
Goodbye
Yeah, bye.
to
Thank you for having us.
And
See you in this afternoon.
Thank you.
Yeah, thank you.
Thank you.
Yes. We'd like to move to another again.